Special Procedures in Emergency Care, Unit 8. This is a pretty lengthy PowerPoint. There's a lot of information. We are not going to go through all the information together. I just want to highlight some things. There are two different types of dressings. One is a sterile dressing. You will never be responsible for a sterile dressing change. The only responsibility you have with a sterile dressing change is if it comes off or is loose and the wound underneath is showing or is at risk of having microorganisms and infection, or it's draining out, or maybe the dressing is soaked and saturated. You need to contact the nurse so she can come out and change that, because that is not a good situation for your resident. You do not remove the dressing. You do not put a new dressing on. Now, you may take some gauze or something and put over the top of the existing dressing while you're waiting on the nurse, but you do not remove the sterile dressing. Now, unsterile dressings you certainly can take care of. Those are little cuts that they might have, that maybe they have, they cleaned it up and put a little piece of gauze and a Band-Aid or something over the top. You can take those Band-Aids off. You can look at the site. You can clean it up, have them wash their hands, dry it, put another piece of gauze over the top. Follow the care plan. The care plan is going to tell you what you can and cannot do and what is expected of you to do with that particular wound. Different types of gauze. So in your box on your screen, A is 4x4 gauze, B is a wrap, C is called an ABD pad, ABD, and that can be used like if you have that sterile dressing that it's kind of bled through or seeped through or something. You can use those ABD pads if you have them and put that as a secured. It's kind of a thick, it adds a little cushion and it's big, so it's going to cover more area. So you can put that down until the nurse is able to come. And then D is 2x2 gauze pads. Anytime you change a dressing, you're going to use universal precautions. Wash your hands, wear gloves. I recommend putting 2 gloves on, so 2 on each hand when you start. And that way, when you take the old off, you remove the tape, you remove the dressing, you put the dressing in your hand, you ball it up, and then you take off your gloves like you have learned in CNA by not contaminating your skin or the gloves underneath. And then you take off the dirty ones, throw it away, and now you have a fresh pair of clean gloves that you can just grab your clean supplies. If it calls in the care plan to rinse, with saline, you rinse the wound, you dry with gauze, you put something over the top. Maybe it's triple antibiotic ointment, put a little gauze over there, tape, a Band-Aid, something like that. Make sure you're observing the skin. What does it look like? Does the skin look macerated? That's kind of where it's a whitey. It looks wet. It looks moist. It looks like the skin's breaking down because it is too wet. Okay. It looks like when you've been in the bathtub too long and you get out and your hands are kind of that white color and looks weird and feels weird. The skin has a different texture. That's macerated. Okay. Macerated is not a good thing. It means skin is breaking down. So you need to dry it. So maybe it needs to be left open to air if it's starting to look that way. It's getting too moist with the dressing over the top of it. Make sure you throw the dirty stuff into the trash and then you take the trash out when you're done. Don't leave that stuff in the patient's home. Talked about checking that. Clean. Cast care. Some of your residents, you may have a resident that you're taking care of that just now is coming home with a cast because they broke a leg maybe or something. They broke an arm. Do not put anything down into the cast. Don't let your client put anything down into the cast because it'll break the skin. It can hurt. Make sure that the cast is covered and is not played with or moved around too much because you don't want dents. Dents can cause damage to the skin underneath, and then you don't know about it until later when the cast comes off, and now we have a whole new issue underneath the cast that we now have to deal with. So read through kind of what you do with the cast. The biggest thing with casts is if you notice that there are like their fingers, that their toes, whatever's protruding from the opposite end, the distal end. You need to make sure that they're not swollen, they're not tingling, they're not painful, there's no odor, because all of those could be signs that either the cast is too tight and is decreasing blood circulation to the remainder of the arm or leg, or there's another issue going on that needs to be addressed. So know about your casts. There are prosthesis or prosthetics. It is not uncommon for a person who has had amputation to have something called phantom pain. Phantom means that they shouldn't have it because the limb is gone. It's like in their head. But you have to remember, as a home health aide and as a medical professional, if they say they're feeling pain in their left foot and their left foot was amputated, you can't discount that and say you don't have a left foot. Because one, they did have a left foot. They do have the nerve endings that are headed down to the foot. The brain doesn't realize that that isn't the foot that is hurting. It's probably hurting right where the foot got cut off and the nerves got blunted and damaged, and it should be going down there, and the brain is thinking that it's down in the foot because that's where those nerves are supposed to be heading. So they do have pain. Notify your nurse if you have that. Maybe Tylenol, maybe other pain medication can be given or can be suggested to the client, but you cannot do that. It has to come from the nurse. If a vaporizer or humidifier is used, the purpose is to improve breathing. It's to purify the air. Make sure you follow the directions, know how the machine itself works. Add water if it needs water. You need to know and understand how to keep that working properly. Make sure that it's not blowing into your patient's face because it can make them sick. Emergency and first aid, the difference: emergencies are sudden, they're unexpected, they're scary, and they're usually serious, and usually it's a 911 call. You need to be able to recognize a real emergency versus something that's not really an emergency, you just need to take care of it, okay? As a home health aide, you have to be able to use your brain and work through some of these scenarios, kind of like being a mom. If you have a child, do I need to go to the emergency room? You don't have to take them to the emergency room for every little thing. You have to be able to discern, is this something that's going to cost them their life if we don't? Or is this something that we can take care of now and see how that works? And if it doesn't work, then go to the doctor. So you need to remain calm, and you need to know what action you need to take. You need to understand all these, on these later slides, all these medical emergencies. You need to understand what they are, how they affect the patient, what the patient's going to look like when it happens, and then what you're going to do about it. And become very comfortable and familiar with those. That way, when it happens, should it happen, you will be prepared. First aid is immediate care given in case of an injury or an accident. They fall down, they hit their head, okay? They're talking to you, they're awake, they're alert. It's not an emergency, it's first aid. But because they hit their head, we may still need to call 911. We definitely need to call the nurse and say the patient fell, and this is how they fell, and this is what happened, and this is what they're complaining about right now, but they're awake, they're alert. It's not emergent, but we do need to have treatment. We need to have care, and we need to look into that. If they hit their head, you want to make sure you stabilize their neck. Don't let them get up and be moving and stuff like that, because they hit their head, they could have hurt their neck, okay? They could have severed something, and we don't know about it. If they're on a blood thinner, you have to know that, and they hit their head. Maybe they have a bleed going on in there, so they still need first aid. They still need to be evaluated. Not necessarily by you, per se. I mean, you do need to evaluate them, but that's not where it ends. You need to notify the nurse and say, hey, this is what happened. What do you want me to do? She may say, call 911, have them evaluated. It's free. They do not have to. There is no cost for 911 to come out and evaluate. There is a cost for 911 to go to the hospital with the patient. So that's where the cost comes in. So there's different obstructed airway. These are emergent situations. If you can't fix them, if you can't make them not emergent, then it's a 911 call. So I'm just going to go through here. I'm not going to discuss any of this stuff. I want you to read through them. You need to understand how to take care of somebody who has an obstructed airway. And yes, you do need to understand for children, because it could be a family member that's in the home. It could be maybe you are taking care of a pediatric patient. You need to know those things, even though we think typically home health is the older adult. It's not always the older adult. We have families that come in too that we need to assist with if something were to happen. Diabetes, you will be able, or you will be required to, on some of your diabetic residents, assist them with getting their blood sugar. You are not doing their blood sugar for them. It's more of a reminder, and then watching them to make sure that they are doing it correctly, and then understanding their diet of what they need to have to maintain their blood sugar. Because if they aren't eating correctly, their blood sugars are going to go up or down. That's energy in their body. It messes up a whole bunch of stuff. So you need to understand diabetes very, very well. So definitely understand that one. If you go to your client's home, there's no knock or there's nobody there, investigate. Go around the house, knock on windows, try to get in, because they're supposed to be there because you're there. And home health, they have to be homebound. So they need to be there. So they're probably inside. Are they inside and watching TV and don't hear the door? Or did they fall and are they hurt? You cannot leave without investigating and figuring out what's going on. If you can't get anybody to answer the door, you've gone around the house, you can't see anything, call 911. Have somebody come out and go in that house. You do not go in that house, but have somebody come out and do that. Call family. Do you know where they're at? Okay. Call the nurse. Let her know. If you discover a client who's unconscious or dead, you need to know your agency's policy. Probably calling the police, calling the physician. You aren't calling the physician. You're calling the nurse or the nurse that's on the case. So make sure you understand that, and also know their DNR status. If you find them unconscious, if you find them not breathing, if you find them with a weak and thready pulse, are you going to give them CPR? Are you going to try to bring them back? That's what's their DNR status. When in doubt, call 911. Bleeding, stop the bleeding. That's the most important thing. Stop the bleeding, then figure out what you're going to do next. Burns, first, second, and third degree burns. Second and third degree burns are pretty bad. Third degrees are life-threatening. So if you have a third degree burn where you're actually seeing black or white skin, you need to probably 911 or call the family and have them go in, depending on how bad the burn is, where the burn is. If it's on the hand, don't need 911 for that. Probably need family to take them to the doctor. Okay, so understand the burns, understand shock. What is it? It is a life-threatening situation. What causes shock? What are you going to do? What's your patient going to look like? What's their blood pressure? Probably going to be dropped. Their heart rate's probably going to be high and thready. They're probably not going to look good. It's not shock like, oh my gosh. It's shock of their body. And their heart's not doing well, and they will die if they're not taken care of. Sometimes it's due to a lack of volume of fluid in their body, and they need to have IV fluids. So they just don't have enough to keep their heart going. So you need to understand that. What happens with falls? If your patient's complaining about their hip hurting or their leg hurting every time they go to stand up, notify the nurse and tell her, I don't know what happened. I don't know if they fell. They're not saying that they fell, but every time they move, this is what's going on. They're complaining of this particular thing. Let them know so that they can come out and do an assessment. You are the eyes and the ears. You are the important person in this entire protocol, in this entire thing, to keep your patient safe. Poisoning. Make sure things are put away. If you see bottles sitting out, put them away so that they don't just go and grab them and drink them or something. Call poison control. Call your nurse. That kind of stuff. Seizures. What are they? What do you do for them? Okay. Chest pain. How are you going to take care of that? you're going to call 911. You need to do some evaluation